Good afternoon. This is the Healthcare Committee, back for our part of our afternoon session. We're going to take up H 73 in this portion. And we're going to start off with our legislative counsel, Katie Glenn. She's going to take us through the bill.
Afternoon, Katie McDonough, Legislative Counsel. Let me share a draft. There we go. Since this committee last looked at this language, there has been some work done on drafting an amendment. So that is what you are seeing in front of you. This first section A of your draft is being struck out instead of amended. That's a big difference since the last time you saw it. And that's because there is an existing inconsistency between the two sections we're looking at with regard to who does the first certification, what professional, whether it is a psychiatrist or a physician. This language that is being struck through says it's a policy choice that it be a psychiatrist, which is different than what it says in section 2, and also not consistent with practice. That's what the testimony you heard. So this language is being struck through. Section 2, instead of, maybe I should just step back and remind us about what we were looking at. We looked at that timeline. I don't want to call it a timeline, but that flow chart of the different elements of involuntary commitment. And one of the initial stages of that is that there could be an application and certificate for somebody to be examined to see if they meet the statutory level of care for involuntary commitment. So that's what we're talking about, is who can fill out that certificate. So I hope that helps sort of reminding us the conversation that we had. Section 2 says that upon a written application, existing law is of an interested party, and the change is a qualified mental health professional, which is a special term. And I want to say it's defined, but I would have to double check that that's true. Made under pains and penalties of perjury and accompanied by a certificate instead of by a licensed physician. This is really the substance of what you're looking at. It could be a healthcare professional who could sign the certificate. And then we have a list below of who could be a healthcare professional. This person is not the applicant, and a person shall be held for admission to a hospital for an emergency exam to determine if the person is a person in need of treatment. That's this statutory defined term for somebody who could be held for involuntary commitment. The application and certificate shall set forth the facts and circumstances that constitute the need for an emergency exam and that show that the person is a person in need of treatment. No changes to subsection B, so I'll skip over that. Subsection C, this has been rewritten because it seemed like the language in the existing law was kind of clunky and folks were having difficulty getting their head wrapped around it. So this is an attempt to make it hopefully more readable. And that language is admission of an individual to a designated hospital for care and treatment under this section shall be overseen by a head of hospital who may designate a person in writing to discharge the authority granted by this subsection, in this subsection. So you're getting rid of a cross-reference that kind of cross-references to nothing because there's no reference to a head of a hospital in subsection A. When we have language that the designated person must be an official hospital administrator, supervisory personnel, or licensed physician on duty on the hospital premises, other than the certifying, again, instead of physician, a healthcare professional. New subsection D, that prior to issuing a certificate prior to this section, a healthcare professional shall successfully complete a training developed and administered by the department, meaning the Department of Mental Health. So that means that any profession who is issuing the certificates would have to go through a training. And it leaves the specifics of what the training looks like up to the department. And then we have our definition, shorter than the last time you've seen it. So we have a physician and APRN, they can already do the certification. So the new addition is a PA, a physician assistant. And that's it.
Very quick clarification. Is department defined elsewhere?
Yes, I believe so.
Everybody digested this?
Elsewhere in this bill?
I don't know about digested.
Elsewhere in statute, yeah. And
I
then
mean-
double check, but
Okay, time out,
Because there's something a little hanging, I just wanted to show.
yeah, I will double check.
time out. When we want a question?
Well, you said, has anyone digested it? I was saying I've eaten it. I needed a minute to digest it. Like I need to like mull it over.
So you need more
I
time?
do have a question, but I'm like trying to I was waiting. Is now the time?
No,
Exactly. So I'll wait.
No, I'm set.
finish.
I'm good.
The
Thank you.
reason I stopped is because she was asking a question.
Yeah, I didn't know what was going on.
I was just clarifying something. Thank you.
All right, now, other questions?
I'm gonna wait to get to the bitter end. No one else.
No questions at all. You did a good job, Katie.
I guess maybe I have one question
Oh.
about the use of, it's a pre-existing word, but to use discharge the authority, is that just understood?
Designate in writing, you have to read it all in context. Who may designate. Somebody to this part,
Line
3.
14.
Yeah, line 14. I feel like the meaning feels clear to me, but if it doesn't feel clear to the committee, we could think of a synonym for that.
It's pre-existing in this,
It is.
in the original draft of this bill.
It's in statute now. Yeah.
I just wasn't sure if it was a term of art in this setting or not, or.
No, I don't think particularly to discharge the authority. I think it just means to carry out as designated.
Any other comments, questions?
I'm just gonna wait till the other witnesses are done, and then if they don't answer, I'll
Okay.
ask it.
All right, Katie, thank you very much. Ian? You want to come up and take the hot seat and introduce yourself? Thanks for coming back, by the way.
Representative Van Donahue, thank you very much for inviting me to comment on this because it's certainly an area that I've followed for a long time. And I just want to, I'm not really thrilled with this, but I'll get through why I think it's probably worth doing. I think it's important to step back and say, this is almost practically the only circumstance in which you can take away someone's freedom to leave a locked facility unless you've been charged with a crime. And so there's a lot of weight to that. If you've been charged with a crime, for one thing, there's got to be probable cause that you committed it. You can't be held without bail unless it's a really serious crime, and this is being held without bail. And it's not some hypothetical future danger. It's you've done something. It's not like you might. We're balancing, obviously, society's altruistic interest in care, but I think we got to keep that in mind. And the safety valves, if you have, that we have in part in this process is 3 parts, and that's my one area of concern. You're dealing just with the middle part. And there's a context of the first and the third. So first there's how does a person who doesn't want to be brought to the hospital get to the hospital? And then there's what's going on in the emergency room. What is it that allows them to be held for 24 hours? And then there's what's the threshold for saying somebody is going to be admitted against their will? And this is dealing with that middle part. My own preference would be there would virtually be no barrier for part 1. And we have warrant requirements and so forth, which I think can be to the detriment of a person and not an extremely high imposition on civil rights. But currently in our third part, we have a serious problem. And that has to do with our lack of providers. That's the reality. But a psychiatrist is supposed to make that decision of whether a person's going to be locked up and held against their will because their illness is so significant and it presents a danger. And that's routinely done by teleconferencing. That's not an appropriate, in my view, that's not an appropriate way to make that kind of a diagnostic and therapeutic decision and able to really interact with a person. And that's why changing the middle one makes me nervous, because if we had a really strong, good part 3 before the big decision to admit somebody and hold them, then, you know, accommodating things with this wouldn't be a huge concern. That's a reality we can't really address. We don't have psychiatrists who can come in the middle of the night in the Northeast Kingdom to assess someone. So we're kind of stuck with that. But I put that as part of, you know, why am I cautious about this? Because we're slightly reducing the amount of the level of review that goes into part 2 when we have a horrific part 3 in terms of protections. So, you know, what is the key to this second part, and why is it reducing it a little bit? I think what people have to be aware is that the physician role in the first certification is not the psychiatric role nearly as much as it is, are there other medical things going on that could be producing the symptoms? There's a huge area that's well documented in healthcare, and I always forget the correct term, but it's basically diagnostic misperception. It's a different word from misperception, but it's the fact that bias exists in our society, implicit bias, unintended bias. And when it comes to psychiatry, people get their medical problems dismissed based on their psychiatric presentation. And I had a sister-in-law who died because of it. She was repeatedly seen in the emergency room with severe stomach pains. She was sent home. It's your psychiatric issues. And she died in bed one night of a physical. So that's really important. And I think we do know that today, advanced practice registered nurses and physicians, or this is adding just specifically physician assistants, are pretty well schooled in all of that diagnostic work. But addressing implicit bias in terms of psychiatry is really still in its infancy in our healthcare system. You know, I would feel better if that was more advanced. I know there's work going on it. Hopefully something like that would be caught at the point of admission by a psychiatrist. But since they can't palpate your stomach or do things like that through a video conference, that weakens it. So I'm saying all those as precautions. I think this should go forward. I think, you know, given the status of, for all sorts of reasons, the issue around people having to wait long periods in emergency rooms, and looking at the person who's on the ground probably most able to make a good decision about that first certification. You know, I am comfortable with it. Waiting a long time in crisis back when I was waiting a long time in an emergency room in a psychiatric crisis, waiting for not even certification, just admission decisions because I was a voluntary patient. And one time, horrible as it sounds, I had to wait 5 or 6 hours. It was horrible. And yet, in the current day, people wait days. And I just can't begin. I'm doing it as a comparison because I know how horrible it was waiting 5 or 6 hours. And yet that's considered super fast today. So waiting and not having your needs addressed, you know, it's a problem that we have to confront and deal with. And so I think this is something that does need to move forward. But I would hope you would keep in mind parts 1 and parts 3. Because they work together, and this is being taken up in an isolation.
And do you have that written, what you've said to us?
I have it written in notes. I could quickly type it up because it wasn't that long.
it would be nice to have that.
Yeah, because none of them are your parts.
Part one is how do you get to the hospital? Part three is how do you get admitted against
To
your
the
will?
treatment.
But
Part
I'll,
two,
yeah.
rule out the medical costs.
Well, it's that emergency room clearance that we think they should be held until a psychiatrist sees them and decides on admission. So I think one of the key functions is ruling out medical causes. You know, it is also a kind of a mental health screening as well in terms of should this person be held for a psychiatric examination for admission. So.
Thank you. Great.
Thanks, Ann.
Thank you so much.
Next next witness is Jen Collin.
There.
How you doing?
Sorry, all.
Thanks for coming in.
Thank you. Well, I'm going to be short and sweet. Jennifer Colin, Director of the Office of Professional Regulation. Thanks for having me today. In the first iteration of this bill, in section C, where healthcare professionals defined, there were numerous professionals listed that are regulated by the Office of Professional Regulation. In this iteration of the bill, those have all been chopped out. So what's left is APRNs. OPR regulates APRNs. My understanding is they were already able to do this well within their scope of practice. If the committee at some future point decides to reconsider other mental health professionals like psychologists or licensed clinical mental health counselors, we'd be happy to come back and testify and give a perspective on that. But at this point, they're not in the bill. As you know, OPR regulates over 50 professions. A lot of those include healthcare professionals. And we license over 80,000 individuals and businesses, and public protection is our mission. So if at any point this bill kind of implicates any of our other professions, we'd love to come back and share more information with you. But right now, APRNs are in there and we're already in there, and that's the one profession we regulate. Board of Medical Practice regulates PAs.
Okay.
Great.
Thank you.
Any questions about that?
Any questions?
Yeah,
Go ahead.
what do you want you would add?
I'm not making any kind of recommendation.
Okay,
And
okay.
this is not our process, so
Oh,
this is
okay.
not a recommendation we would make. What I was saying is if this committee is going to reconsider at any point because of access issues or whatever, adding in other professionals, we'd be happy to come back and talk.
Okay, we appreciate it.
Okay.
Really quick, sorry.
Yes,
ma'am.
Your last sentence, you said the Board of Medical Practices regulates.
Physicians assistants, PAs, and so they're the profession that was added in section
Yeah.
C.
Oh, okay.
So they would probably have more to say on that. Great. Thank you so much.
Hidden testimony.
I know.
Thank you very much. Now we have two witnesses that are on Zoom. The first one is Philip Schaefer. He's emergency physician assistant, emergency room physician assistant.
You guys froze.
There you go. Hello. Can you hear us?
Your guys' video and audio froze on me. I'm not sure if the problem is at my end. Oh, there we are. Can you guys hear me?
Yes.
Yep, now we can, yep.
Okay, sorry. For some reason, the audio and visual froze, and the audio has been coming through choppy. I hope the problem is not at my end, but let me know if it is not clear. Thank you for allowing me to present some testimony today. Thanks for allowing me to do it remotely, so I didn't have to drive up to see you guys, although I have been anxious to see Vermont's capital since I've moved here. My name is Phil Schaefer. I'm a physician assistant. I've been practicing emergency medicine for just over 30 years. I've just been in Vermont for just over 4 years, however. I work at Grace Cottage Hospital, which is a very small critical access hospital in Townsend, Vermont, southeast Vermont. And this bill is important to me and to us in our practice for a couple of reasons, and I promise to keep it short and sweet. Being a critical access hospital, often the only emergency provider is a PA or an APRN or a nurse practitioner. Sometimes we have physicians depending on the scheduling. And at our place, we have hospitalists during the day, which again can be a physician or a APRN or a PA. But we have very limited resources, as a lot of hospitals in Vermont do. After about 5 or 6 in the evening, the emergency provider is the only provider in the hospital at our place for the rest of the night. And the hospitalist or physician or supervising physician are available by phone. Routinely, psychiatric patients or patients that family or friends or EMS is being called for come into the emergency department to be screened for clearance for admission to the hospital. The vast majority of them are voluntary. They want help. They realize they're in a crisis and they're seeking help, whether it be inpatient or outpatient. But on a regular basis, PAs are called on to decide whether it's a medical or a psychiatric condition. And if it's a medical condition, we deal with it on the medical side. We also see patients who are unable to recognize they need care or are in extremis, and we have to I don't want to use this. This is all about, taking away somebody's liberties or their ability to make decisions for themselves. But this happens on the medical side quite a bit with head injuries and encephalopathies or other disease processes that involve cognitive function. And so we see and deal with this and make decisions based on that quite a bit independently. So it's not outside our scope to also decide when somebody clearly is suicidal or homicidal and clearly does not recognize the need for attention and also is not interested in getting help. And so in the evenings and nights when these folks present, the decision that is made to put somebody under emergency evaluation status or EE status is sometimes pretty complex. You have to involve, you're out in the waiting room talking to often their parents or their loved ones, their neighbors who are witnessing what's going on every day, and are giving you clues on the patient's recent activities and what they've said, and what presents as a danger to themselves or others, and you spend quite a bit of time in the room and hopefully developing a rapport with the patient. That becomes very complex and confusing sometimes, quite confusing to the patient when you add another person. You've decided, okay, I've talked to all the interested parties, and now you need to get somebody else involved, i.e. the physician, to come in and start the process over because they have to certify that they've evaluated this patient for X amount of time, that they've spoke to these folks, and repeat the process. Now, it's not without worth doing if it leads to better outcomes or for more accurate care for the patient. But I would argue that it currently only serves to extend the amount of time they're in the emergency department, which is a horrible place for patients who are seeking psychiatric care because they often get very little. I mean, they get their medications if they're willing to take them, but they don't have an on-site. We don't have an on-site psychiatrist. We have HCRS come in, the crisis worker evaluates them, but they don't make recommendations on treatment and they don't alter their treatments while they're in the emergency department. So these folks just kind of hang out. And as Anne, I apologize, I didn't get Anne's last name, as she testified at the beginning, hours seems like days to these folks. And when you're talking about extending it by several more hours just to get another person involved and repeat the process, it can be very upsetting to the patients. It can be upsetting to everybody else involved. It can be confusing to the patients and everybody else involved. And so I think this is important. I do not think that there is a decided that is detrimental to the patients. This is a decision that we do not take lightly, and it involves a lot of thought and input before the decision is made. That's pretty much all I wanted to say. I just want to make myself available to answer questions from the representatives if you have them.
All right, thank you. Questions?
Thank you for being here, there. Um,
Sure, thank you.
There is this training component, subsection D, Department of Mental Health. How do you view that aspect of the legislation?
I think that's great. Where I came from, where I spent most of my practice, over 25 years in Michigan, we did not have that. It was basically on-the-job training. And when I came here 4 years ago, my boss, who is very involved in this type of issue, pointed us to that website, said, look, PAs can't certify for EE, but you ought to go through and see what our criteria is and what the rules and regulations are. And it's a good resource. I think that's excellent. I think that Vermont has set up a nice program there.
Thank you.
Other question?
I have a quick question. We just heard about implicit bias, and does the training cover that? I'm just worried about it now that I've heard it, that when someone comes in with medical issues, that because they might have a psychiatric history, is there in the training that you do, does that cover? I don't know. I'm not making the diagnosis, but, excuse me?
I'm not sure if that question was for me or for the representative there who knows about the training or how.
She's not there anymore.
Okay,
For
sorry. Yeah, so that is step number one. I mean, when people are presented to the emergency department for clearance, as we would call it, that is goal number one. Is this an encephalopathy? Is this a medical condition that's causing a detriment to their capacity or their decision making? And if so, we need to address that. That actually is the first process before psychiatry, before HCRS gets involved, before the first cert is done, is to decide. And sometimes that involves CAT scans, sometimes that involves labs and drug screens, and sometimes it involves observation. If they're intoxicated, we observe them for a while and see, are they still imminently suicidal when they're sober, that type of thing. And so I agree with you. That bias is real in medicine. It is real when it comes to psychiatric and medical, organic medical conditions. Having a diagnosis bias is a real problem in medicine, and we should all strive to minimize that and to keep an open mind.
Thank you.
Other questions? Okay, thank you very, very much for taking the time
Sure, thank you.
to enlighten us. Okay, last witness is Trey Dobson. He's an MD in the emergency department down at Dartmouth Health.
Hi there. Well, first off, I want to recognize Representative Donohue's comments. They were right in line with a lot of the physician thinking and Phil's comments. And I don't want to sound like an echo chamber, so maybe I'll just make a few things. First off, it's as Phil said, it's well within the capability of a trained physician assistant to make these decisions, to determine whether or not a patient has decision-making capacity. And they also have the resources of a physician, typically by phone or somewhere in the building. And physicians use physicians for the same thing all the time. If you didn't, you wouldn't be a good physician. The second, all the discussion on bias is, that's very prevalent in medicine now. It was not 15 to 30 years ago for sure, but we're not just talking about mental health presentations. If Phil or I see someone with heart failure, the first thing we say is, who said it's heart failure? Put that diagnosis off to the side, try to make sure it's something, not something else. And that's certainly true with mental illness. And, we have a lot of staff around us and they are, doing their thing, talking. We make sure we just silence and work on, first off, is there a life-threatening condition going on? And that can take a few hours, as Phil noted, sometimes requires adjunct tests. So I have, no problem with this bill. In fact, I've been practicing here for 21 years, and I've always found it a little ridiculous that I have to come in after someone who's got the capabilities and has made a decision and come in and verify it, which of course I do without bias. I set it to the side. I spend over an hour, and the value added is very little. I don't think once in practice I've quote overturned someone else's decision on that. And remember, we do this all the time with medical, and it's not involuntary first certification. People come in, as Phil noted, with encephalopathy, intoxication, injury, illness, cancer, electrolyte abnormalities that want to leave. And, we can't let them leave. That's our responsibility, is to provide care for them. Here, we've ruled those things out, and we have said, this appears to be a mental illness where you do not have the capacity to understand the consequences of your decisions, at least not right now at this point. And so we need to hold you involuntarily for a second certification by a psychiatrist. Perhaps, your situation will change by then, because it often takes a while, or perhaps not. And at that point, you need inpatient treatment to help you through this difficult time. So I'm available for questions too, as Phil said, not only now, but at any time. And I don't want to just keep, saying the same thing over and over.
Okay, thank you, Doctor. Questions? Sounds like everybody knows.
Pretty straightforward.
Pretty straightforward, is right. All right, sir. Thank you very much to both of you.
Thank you.
Thank you.
Thank you. Thank you very much.
You're welcome, and thank you.
Okay, we can go off.